Welcome to the December 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the December issues of the journal, as well as commentaries by Dr. Timothy A. Damron on the article entitled Aspirin for Prophylaxis against Venous Thromboembolism after Orthopaedic Oncologic Surgery, and Dr. Richard W. Kang on the article entitled Quantitative Assessment of Femoral Head Perfusion Following Arthroscopic Femoral Osteochondroplasty, a Cadaveric Study. Be sure to check out this month's Current Concepts Review article, Diagnosis and Management of Sacroiliac Joint Dysfunction, by Dr. David O. Yang and colleagues. The authors note that a constellation of findings, including pain referral patterns, provocative maneuvers, and response to injections, should be utilized when assessing sacroiliac joint pathology. While its effectiveness remains unsubstantiated, manipulation of the sacroiliac joint is non-invasive and warrants consideration as an initial treatment modality. The authors report that sacroiliac joint fusion appears to be emerging as an acceptable treatment for patients with recalcitrant sacroiliac joint dysfunction, although only a few long-term outcome studies have been done. In addition, new minimally invasive fusion techniques appear to decrease the morbidity of open procedures with at least comparable outcomes. In this issue, JBJS.org presents a new image quiz, a 51-year-old man with a worsening limp. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Aspirin for Prophylaxis against Venous Thromboembolism after Orthopaedic Oncologic Surgery, by Dr. Gregory M. Mendez and Associates. Investigation performed at Cooper University Hospital, Camden, New Jersey. Patients who undergo orthopedic oncologic surgical procedures are at increased risk of developing a venous thromboembolism, VTE. Guidelines from surgical societies are shifting to include aspirin as a postoperative VTE prophylactic agent. The purpose of this study was to review the author's experience using aspirin as postoperative VTE prophylaxis for orthopedic oncologic surgical procedures. This study was a retrospective review of patients diagnosed with a primary malignant soft tissue or bone tumor or metastatic carcinoma. Demographic information, histopathologic diagnosis, VTE history, surgical procedure, and VTE prophylaxis were analyzed. VTE rates in the overall and prophylactic specific cohorts were recorded and compared. A total of 142 distinct surgical procedures in 130 patients were included. VTE prophylaxis with aspirin was used after 103 procedures, and non-aspirin prophylaxis was used after 39. In 33 cases, imaging was used to investigate for VTE because of clinical signs and symptoms. VTE developed after 4.9% of the 142 procedures. There were 6 deep venous thromboses, DVTs, and 1 pulmonary embolism, and 2 of the VTEs presented in patients with a VTE history. VTE developed in 2.9%, 3 of the 103 aspirin cases, and 10.3%, 4 of the 39 non-aspirin cases. No patient in the aspirin group who had been diagnosed with metastatic carcinoma, malignant soft tissue sarcoma, lymphoma, or multiple myeloma developed a VTE. Risk factors for VTE development included diabetes mellitus, odds ratio OR equals 10.40, 95% confidence interval, CI equals 1.61 to 67.30, a history of VTE, OR equals 7.26, 95% CI equals 1.19 to 44.25, postoperative transfusion, OR equals 34.50, 95% CI equals 3.94 to 302.01, and estimated blood losses of 250 milliliters, OR equals 1.50, 95% CI equals 1.11 to 2.03, 500 milliliters, OR equals 2.26, 95% CI equals 1.23 to 4.13, and 1,000 milliliters, OR equals 5.10, 95% CI equals 1.52 to 17.04. Conclusions. Aspirin may be a suitable and effective option for VTE chemoprophylaxis in patients treated with orthopedic oncologic surgery, especially those diagnosed with a soft tissue sarcoma. Research with a more advanced study design is required. Next, you'll hear a commentary by Dr. Timothy A. Damron on the article entitled Aspirin for Prophylaxis Against Venous Thromboembolism After Orthopaedic Oncologic Surgery.
This is Dr. Timothy A. Damron, providing commentary for the December 2017 JBJS podcast. I will be providing commentary on the article entitled Aspirin for Prophylaxis Against Venous Thromboembolism After Orthopaedic Oncologic Surgery. The title of my commentary is Wishing It True Doesn't Make It So. In this article, Mendez et al. Offer their experience with use of aspirin for venous thromboembolism prophylaxis, specifically in orthopedic oncology patients. They conclude that aspirin is a suitable chemoprophylactic agent. I wish this were so because aspirin is such a simple agent to prescribe and use. However, few topics in orthopedics are as controversial as the selection of appropriate prophylaxis postoperatively. Prophylaxis for VTE in general has been the focus of numerous randomized prospective clinical trials with level 1 evidence. But even those have not always agreed. Hence, study panels of the American College of Chest Physicians, American Academy of Orthopedic Surgeons, and American Society of Clinical Oncology continue to publish guidelines based on their interpretation of the latest literature. Despite these guidelines, there is considerable flexibility in a physician's or surgeon's choices for VTE prophylaxis. The controversy about VTE prophylaxis has been particularly contentious with respect to aspirin. As noted by Mendez et al., the ACCP guidelines recommended against its use in 2008, but then added aspirin as an acceptable agent in 2012. ASCO guidelines recommend against aspirin use and suggest only unfractionated heparin or low molecular weight heparin be used for patients with cancer who are undergoing major surgery. However, they do allow for aspirin use in patients on chemotherapy for myeloma. Citing ambiguity in the evidence, the AAOS guidelines allow use of aspirin as well as a pneumatic compression device or any other chemotherapeutic agent for postoperative VTE prophylaxis following hip and knee arthroplasty. Mendez et al. Are correct in asserting that universal surgical guidelines do little to direct the orthopedic oncologist in the selection of VTE prophylaxis. However, does their article provide us the missing but desired direction? I believe that it is difficult to know how to use their findings. First, the number of patients in their study was relatively small, 130 patients with a total of 142 procedures. In a recent systematic review and meta-analysis of computerized clinical decision support systems for VTE prophylaxis, 11 publications involving 156,366 subjects were reviewed. Even among 7 prior studies of VTE in orthopedic oncology, the average number of patients was 348. Moreover, 5 of those studies were focused on incidence and risk factors for VTE. The only 2 treatment studies in orthopedic oncology involved 348 subjects treated with aspirin and a pneumatic compression device, or with low molecular weight heparin and a pneumatic compression device, and 986 subjects treated with low molecular weight heparin. Second, although this was a retrospective study and hence intention to treat analysis was not applicable, the authors clearly intended for all of their patients to receive aspirin. However, only 73% did so. Reasons for protocol deviation included an outpatient operative procedure not requiring chemoprophylaxis, patient refusal, aspirin allergy, VTE history, and a desire for a readily reversible option in case an early return to the operating room was necessary. Third, the orthopedic oncology patient population studied by Mendez et al. Was broad in its scope of inclusion criteria, which included metastatic carcinoma, myeloma, lymphoma, and sarcoma, further diluting the numbers for subgroup analysis. It also differs somewhat from prior reports in that more than one-half of the patients had metastatic carcinoma, whereas some larger studies in orthopedic oncology included predominantly or exclusively patients with sarcoma. Thus, we must greatly temper our enthusiasm for the conclusion that aspirin is a suitable agent with the realization that the data are based on a small number of patients relative to the large body of literature on this topic. Also, the study was not a pure evaluation of patients treated only with aspirin, but rather a real practice evaluation in which there were protocol deviations for various reasons. Hence, its conclusions should not be extended to patients who had outpatient surgical procedures or a VTE history, for instance. Finally, although a broad range of orthopedic oncology diagnoses were included, this actually makes it difficult to know how readily the results could be applied to patients with any one of those diagnoses. In conclusion, as much as I want aspirin to be a safe and efficacious VTE chemoprophylactic agent for all of my orthopedic oncology patients, these results should not be interpreted as definitive support until additional studies are done.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Outpatient Total Knee Arthroplasty is Associated with Higher Risk of Perioperative Complications by Armin Arshi and Associates. Investigation performed at the Department of Orthopedic Surgery, David Geffen School of Medicine at UCLA, and the Department of Orthopedic Surgery, Keck School of Medicine of USC, Los Angeles, California. As concerns regarding healthcare expenditure in the U.S. remain at the national forefront, outpatient arthroplasty is an appealing option for carefully selected patient populations. The purpose of this study was to determine the nationwide trends and complication rates associated with outpatient total knee arthroplasty, TKA, in comparison with standard inpatient, TKA. The authors performed a retrospective review of the Humana subset of the Pearl Diver Patient Record Database to identify patients who had undergone TKA, current procedural terminology CPT code 27447, as either outpatients or inpatients from 2007 to 2015. The incidence of perioperative medical and surgical complications was determined by querying for relevant international classification of diseases, 9th revision ICD-9, and CPT codes. Multivariate logistic regression analysis, adjusted for age, sex, and Charlson Comorbidity Index, CCI, was used to calculate odds ratios, ORs, of complications among outpatients relative to inpatients treated with TKA. Cohorts of 4,391 patients who underwent outpatient TKA and 128,951 patients who underwent inpatient TKA were identified. The median age was in the 70 to 74 year age group in both cohorts. The incidence of outpatient TKA increased across the study period. R squared equals 0.60, P equals 0.015. After adjustment for age, sex, and CCI, outpatient TKAs were found to more likely be followed by tibial and/or femoral component revision due to a non-infectious cause. OR equals 1.22, 95% confidence interval. CI equals 1.01 to 1.47. P equals 0.039. Explantation of the prosthesis. OR equals 1.35. CI equals 1.07 to 1.72. P equals 0.013. Irrigation and debridement. OR equals 1.50. CI equals 1.28 to 1.77. P less than 0.001. And stiffness requiring manipulation under anesthesia. OR equals 1.28. CI equals 1.17 to 1.40. P less than 0.001. Within 1 year. Outpatient TKA was also more frequently associated with postoperative deep vein thrombosis. OR equals 1.42. CI equals 1.25 to 1.63, P less than 0.001. And acute renal failure, OR equals 1.13, CI equals 1.01 to 1.25, P equals 0.026. Conclusions. With the potential to minimize arthroplasty costs among healthy patients, outpatient TKA is an increasingly popular option. Nationwide data from a private insurance database demonstrated a higher risk of perioperative surgical and medical complications, including component failure, surgical site infection, knee stiffness, and deep vein thrombosis. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Quantitative Assessment of Femoral Head Perfusion Following Arthroscopic Femoral Osteochondroplasty, a Cadaveric Study, by Dr. Lionel E. Lazaro and Associates. Investigation performed at Hospital for Special Surgery, New York, New York, and Citigroup Biomedical Imaging Center, Weill Cornell Medicine, New York, New York. Disruption of the arterial supply to the femoral head and subsequent development of femoral head osteonecrosis is of serious concern with intracapsular hip procedures. However, the effect of arthroscopic femoral osteochondroplasty on femoral head perfusion is unknown. The authors aim to quantify the effects of both standard and posterior-superior extension of arthroscopic femoral osteochondroplasty on femoral head vascularity. The authors hypothesized that extension of the superior resection zone posteriorly would negatively affect femoral head perfusion. In 12 cadaveric pelvic specimens, the authors cannulated the medial femoral circumflex artery, MFCA. 1 hip per pelvis was randomly selected to be in one of 2 experimental groups based on the superior extent of the osteochondroplasty: standard resection, resection anterior to the 12 o'clock, 0 degrees of 360 degrees position, or extended resection, resection extended posterior to the 12 o'clock position. Computed tomography, CT scans, were obtained prior to and following arthroscopic resection to delineate the resection margins. Gadolinium enhancement on magnetic resonance imaging, MRI, was quantified in the femoral head by volumetric analysis using custom software. A polyurethane compound was injected and gross dissection of the vasculature was performed. Extension of the osteochondroplasty posteriorly, the extended resection group, to a mean of 41.3 degrees, range 34 degrees to 47 degrees, posterior to the 12 o'clock position, decreased femoral head perfusion by a mean of 28%, range 18% to 38%. The standard resection group demonstrated a mean decrease in femoral head perfusion of 7%, range 4% to 11%. Correlation analysis demonstrated a significant negative correlation coefficient, minus 0.877, p less than 0.001. R squared equals 0.747. For every 1 degree that the superior resection margin extended posteriorly, a corresponding 0.88% decrease in femoral head perfusion was found. Conclusions. Femoral head perfusion is almost fully maintained with arthroscopic osteochondroplasty when the superior resection margin is anterior to the 12 o'clock position. Perfusion is also well maintained if the superior resection margin is extended no more than 10 degrees posterior to 12 o'clock. Further posterior extension correlated with greater decreases in femoral head perfusion. Next, you'll hear a commentary by Dr. Richard W. Kang on the article entitled Quantitative Assessment of Femoral Head Perfusion Following Arthroscopic Femoral Osteochondroplasty, a Cadaveric Study.
This is Dr. Richard W. Kang, providing commentary for the December 2017 JBJS podcast. I will be providing commentary on the article entitled Quantitative Assessment of Femoral Head Perfusion Following Arthroscopic Femoral Osteochondroplasty, a Cadaveric Study. The title of my commentary is Blood is Thicker Than Water. Preserving the vascular supply to the femoral head is one of a myriad of factors that the surgeon must be mindful of during an arthroscopic femoral osteochondroplasty. Although the likelihood of compromising the vascular supply to the point of developing osteonecrosis is low, this can be a devastating complication for a patient. There have been a number of studies that describe the anatomy of the medial femoral circumflex artery in supplying blood to the femoral head. However, we have a limited understanding of how much a femoral osteochondroplasty procedure can decrease the blood supply to the femoral head. Lazzaro and colleagues attempt to bridge this gap with their study, in which they quantified the effect of arthroscopic femoral osteochondroplasty on femoral head perfusion. They found that the farther the superior margin of resection was extended posteriorly, the greater the loss in femoral head perfusion. The specimens in their standard resection group with resection anterior to the 12 o'clock position demonstrated a mean decrease in femoral head perfusion of 5%. The minimally extended resection group, in which resection extended just posterior to the 12 o'clock position by less than or equal to 10 degrees, demonstrated a mean decrease in femoral head perfusion of 9%. In contrast, the extended resection group, in which resection extending an average of 41.3 degrees posterior to the 12 o'clock position, demonstrated a mean decrease in perfusion of 28%. The authors found that these differences in femoral head perfusion were significant across the groups. It is also important to note that their quantitative findings are consistent with what is already known in the literature regarding the anatomy of the blood supply to the femoral head. Although the results of the study are compelling, the reader should also take into account that the methods only focus on varying resection margins based on the clock face. Additionally, the maximum depth of resection was 10 millimeters. In clinical practice, resection margins can vary with respect to the proximal and distal extents as well as depth. The depth of resection performed in this study was deeper than that noted in the literature. For example, Aoki and colleagues recently described a trough technique in which the depth of resection was between 3 to 5 millimeters in most cases, with some exceptions for larger Kang lesions. Philippon and colleagues described a depth of resection of 5 to 7 millimeters. One can argue that the depth of resection can also affect femoral head perfusion. Perhaps variables such as depth of resection as well as the proximal distal extent of resection can be investigated in future studies, quantifying their effects on femoral head perfusion. Lazzaro and colleagues were astute in mentioning that the results of the study should be interpreted with caution. Although they were able to quantify the decrease in femoral head perfusion, the threshold at which a loss in femoral head perfusion becomes clinically important is unknown. Additionally, beyond the extent of resection during a hip arthroscopy procedure, there may be other factors that contribute to the development of osteonecrosis. This may include traction time, increased intra-articular pressure, amount of traction, and direct injury to the vessels from other instruments used during a hip arthroscopy. It is important to recognize that determining the extent of resection during a femoral osteochondroplasty can be challenging. Not only can over-resection lead to vascular compromise, but it can also lead to violating the suction seal effect between the labrum and the femoral head. Under-resection can result in persistent cam lesion impingement, which can fail to alleviate symptoms and lead to revision hip arthroscopy. Proper preoperative planning, including a thorough evaluation of radiographs and advanced imaging, can help the surgeon determine the extent of resection needed. Intraoperatively, the surgeon should clearly visualize anatomic landmarks and use fluoroscopy and dynamic arthroscopic evaluation to help determine resection margins. Additionally, the surgeon should also consider staying more superficial with the depth of resection as the margin of resection moves more posteriorly. Clearly, there are many factors involved that a conscientious surgeon needs to consider when performing a femoral osteochondroplasty. Lazzaro and colleagues should be lauded for investigating one of these factors in depth and helping to bring to light the importance of preserving the blood supply to the femoral head.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Intravenous and Topical Tranexamic Acid Alone are Superior to Tourniquet Use for Primary Total Knee Arthroplasty, a prospective randomized controlled trial by Drs. Ziyu Huang, Zhaowei Ji, and Associates. Investigation performed at the Department of Orthopaedic Surgery, West China Hospital, West China Medical School, Sichuan University, Chengdu, Sichuan Province, People's Republic of China. Tourniquet use during primary total knee arthroplasty is thought to reduce intraoperative blood loss and improve visibility. The author's goal was to investigate whether tourniquet use is necessary for controlling intraoperative blood loss when alternatives such as tranexamic acid, TXA, are available. 150 patients were equally randomized to 3 groups. Group A was treated with a tourniquet as well as multiple doses of intravenous TXA, 20 milligrams per kilogram, 5 to 10 minutes before the skin incision, and 10 milligrams per kilogram, 3, 6, 12, and 24 hours later, along with 1 gram of topical TXA. Group B was treated the same as Group A, but without the tourniquet, and Group C was treated with the tourniquet only. The amount of intraoperative blood loss was similar for the 3 groups. Group B had significantly less hidden blood loss than Group A, P equals 0.018, and Group C, P less than 0.001. No significant differences, P greater than 0.05, were observed between Group A and Group B with regard to total blood loss, drainage volume, intraoperative blood loss, transfusion rate, or maximum change in the hemoglobin, HB level. The authors also found significantly more benefits for Group B compared with Groups A and C with regard to postoperative swelling ratio, levels of inflammatory biomarkers, visual analog scale, VAS, pain scores, range of motion at discharge, Hospital for Special Surgery, HSS score, and patient satisfaction. There were no significant differences, P greater than 0.05, in the deep venous thrombosis or pulmonary embolus rates among the 3 groups. More wound secretion was observed in the groups in which a tourniquet was used. Conclusions. Patients treated with multiple doses of intravenous and topical TXA without a tourniquet had less hidden blood loss, a lower ratio of postoperative knee swelling, less postoperative knee pain, lower levels of inflammatory biomarkers, better early knee function, and even better early satisfaction than those treated with a tourniquet. Long-term follow-up should be performed to evaluate the effects on prosthetic fixation and long-term survival of total knee arthroplasty performed without a tourniquet. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.